So, good afternoon, everyone. On behalf of BLK Center for Child Health, in association with IAP Central Delhi, we are presenting to you another webinar in BLK TelePeds webinar series. And this topic is again common and important for pediatricians to know about. And to chair today's session, we have with us Dr. Shikha Mahajan. Ma'am is Associate Director Pediatrics at BLK Center for Child Health. She is Adolescent Health Specialist and National Facilitator for Adolescent Health. And she is also National ALS Instructor. Welcome to you, ma'am. And we also have with us Ms. Satinder Walia. She is Consultant Child Psychologist at BLK Max Super Specialty Hospital. She did her bachelor's in clinical psychology from University of Delhi and master's from University of Central Oklahoma, USA. And she also she has worked at multiple prestigious institutions like Gangaram Hospital, Medanta Hospital, and she has also closely worked with several schools as a child psychologist. Welcome, Dr. Satinder. Are you there, Dr. Satinder? Now I request our chairperson, Shikha ma'am, to introduce today's session and the speaker. And unfortunately, Dr. Subhash Arya cannot join us today. Sir is also doing some work he's currently working with some orphanages and for the cause of marginalized children. Over to you, Shikha ma'am.
Good afternoon, everyone, and welcome to the webinar from BLK Maths Pediatrics Department. Today's topic is something which is very relevant to all pediatricians, all general pediatricians. Most of us have seen children who have been brought for adoption by the respective parents from different agencies. And there are a lot of legal and medical issues which have to be addressed in these adoptive babies in the initial assessment and later on also as these babies grow and come for follow-up. To discuss all these medical and legal issues, we have Dr. Amit Tyagi with us. Dr. Amit is working as a senior consultant Department of Pediatrics at BLK Max Super Specialty Hospital. He is well qualified from KJMC Lucknow and has been working at BLK Pediatrics since its inception from 2008. His main areas of interest are intensive care and child adoption, and presently he is President IAP Central Delhi. I hand over to Dr. Amit for his presentation.
Thank you, ma'am. So, can you see the slide, ma'am? Hello? Hello?
Yes, Dr. Amit, we can see your slides.
So, okay. Good afternoon, everyone. So, thank you, ma'am. So, we start today's afternoon session, which is on child adoption. We will discuss about the legal and medical aspect of the adoption, and which will help us to evaluate a child who is going to be adopted, and also help us to count in counseling the parents who is going for adoption of a child. So we will go through this topic in first of all, we will discuss about the statistics in India, then what are the different eligibility criteria, what are the categories of adoption, how is the process, and then the medical examination of a child, and what is the child study report, and who are the child with a special need, and who is the child who is hard to place child. So before we go in detail, first we should look some adoption criterias and what are the words we use. The adoption is basically when a child is lawfully adopted by a parent, and the child has all the responsibility, all the rights as the biological child. When the child is adopted, he lawfully becomes a child similar to a biological child. So the parents who are going to adopt a child is called PAPs, or prospective adoptive parents. Another terminology is OAS child. We frequently use this terminology, OASPs, a child who is orphaned, abandoned, or surrendered. And these child are also come in category of CNCP child, that is child in need of care and protection. There are many stakeholders in the process of this process of adoption, from the central governments to the child care institute. The central government unit, which is called CARA, is Central Adoption Resource Authority, and at central level, which comes under the Ministry of Women and Child Development. And another is SARA, which is called State Adoption Resource Agency. Other agencies are like Specialized Adoption Agency, which helps in this process, CDPU at district level, Child Care Institute, we can call it orphanages, then Child Welfare Committee, Adoption Committee, and Authorized Foreign Adoption Agencies, we call it AFA, which help in adoption process for foreign adopted parents. Another terminology is called foster care. The foster care is when the child temporary custody is given to the parents who are going to adopt the child. So they call this foster family care. Kinship care is called is when the child is given it to a close relative or close family, and they have this child, and then it is called kinship care. So then we come to the statistics. The present. You can see this is the pie graph. You can which shows the legally free child for adoption from 2018 to 2023. You can see the red portion of this pie chart, which constitute the special need child. So around 50 to 75% of the child which are legally free, they constitute major part, and only 25% to around 40% child are healthy child, which are in like less than 2 years, only 2 to 4%, and the child above 2 years only 20 to 25%, and child who are siblings are around 8 to 9%. So the children who are most in demand are less than 2 years of age, which constitute only 2 to 3%. So this slide shows the number of adoption in the country, which shows a decline from 2011. The total number of the child adopted were around 5,693 in country adoption, and which has come down in a decade to around 3,142. So this number shows the declining trend of adoption in last one decade. This is the current data, adoption data year 2023, which shows that only around 1,500 kids has already been adopted, and around 2,110 childs are in waiting for adoption. So around 3,500 kids are there for adoption. And you can see the interesting thing is that the parents who are listed and who are waiting for adoption of a child, the number is around 35,000. So the ratio you can see is around 1:10 times. So this is a huge gap, and the reason maybe this huge gap between adoption and the child and PAPs is maybe because of lengthy procedure of adoption, or maybe some unethical practice. So this was the whole data, the statistics about the adoption. Then there are some laws in India. There are 3 laws basically which governs the adoption in India. One is the Hindu Adoption Law, the second is Guardian and Ward Act, and third is Juvenile Justice Act. The Hindu Adoption and Maintenance Act, which was formalized in 1956, in this act, only the Hindu male or female or married couple can adopt a child who is born and brought up as a Hindu. Hindu means all Hindus, Jain, Sikhs, Buddha, they come under this law, and they can adopt a child. The minimum gap of the age between the child and adopted parent is 21 years in this, according to Act, and the maximum age of child who can be adopted is 15 years. Under this Act, the child who is adopted has all rights similar to a biological child. and the adoption which is done under this act is irrevocable. The second act, which is Guardian and Ward Act, as the name suggests, this once the parents take the guardianship of the child, they don't adopt the child technically. So the relationship in this act is only guardian and ward. This act applies to non-Hindus in that religion, like Muslim, Christian, Jews, who do not adopt the child. But if any individual want to take a guardianship, he or she can take a child and become a guardian till 21 years of age. And after that, the child is not equally don't have any rights equal to a biological child, like in Hindu adoption and maintenance. So here the relation is only the guardian and ward. Like the third act is Juvenile Justice Act. This JJA, the Juvenile Justice Act, is like a secular type of act which was given in 2000 by the Parliament, and under this is not based on any religion criteria, any person, child of any religion. But so we will whatever criteria and process we will discuss according to this Juvenile Justice Act in our Pradesh. Of a child for adoption, if the child is OAS, as I told, the child is orphan, abandoned, or surrendered, and is legally free, so that child can be adopted. A child of a relative, like a paternal or maternal uncle or grandparents, can adopt a child. And third one is a child of spouse from earlier marriage. So these are the three types of child which can be adopted under this Juvenile Justice Act. Now there are 5 categories of adoption. The first category is in-country adoption, that is the Indian resident residing in India. Second is inter-country adoption, that the non-resident Indians, overseas citizen of India card holder, foreign prospective adoptive parents can adopt the child. In-country relative adoption and inter-country relative adoption, and last, the adoption by the step-parent. So these are different categories of the adoptions. And the Indian resident, non-resident Indian, and overseas citizen of Indian card holder are at par in this adoption act. So there is a waiting list, and the Indian residents or non-resident Indians and overseas Indians, they are equally given this reference. Now, what are the different eligibility criteria for prospective adoptive parents? The parents who are going to adopt a child living within or outside country, the first criteria is that the parent should be physically, mentally, emotionally, and financially capable. There should no life-threatening medical condition in parents. They are not convicted in any criminal act and not accused in child rights violation. The second criteria is based on any PAP can adopt a child irrespective of their marital status. Like consent, like any married couple, but consent of both married couples should be there, and with at least 2 years of stable marital relationship. Then a single female can also adopt a child of any gender, but a single male will not be able to adopt a girl child according under this act. So if a married couple has 2 kids, they cannot adopt a child, but they adopt a child with a special need or a child who is hard to place. So if a married couple has 1 child, then they can adopt another child, but if they have already 2 child, they cannot adopt the 3rd child, except they can adopt a special need child or a child who is hard to place. The third criteria for PAPs is the age. You can see that there is a different age-wise criteria, but this age criteria to parents does not apply in case of relative or any step parents who wants to adopt a child. So this criteria, according to this criteria, the age gap of child and PAP should not be less than 25 years. Means at least the gap of the child and PAP should be 25 years. So you can see this, if a child is 0 to 2 years and the maximum composite age of a adoptive parent couple is more than 85 years, they cannot adopt a child less than 2 years. So 85 years, if the composite age of both parents is 85 or less, they can adopt a child less than 2 years or more. But if the age is more than 85 years or maximum age of a single PAP is more than 40 years, they cannot adopt a child less than 2 years. So you can see a parent whose composite age is 90 years, they can adopt a child between 2 to 4 years and above. But if the parent's composite age is more than 90 years or if one single parent is 45 years, they cannot adopt a child between 2 to 4 years. So similarly, this is the age criteria for the other age group also. These criteria are under the Juvenile Justice Act. Now the question arises that can a OS newborn baby can be adopted? Like when you read in a newspaper that someone find a child in garbage or someone find a child who is abandoned. So you cannot or anyone cannot directly adopt a child. The process is there that anyone who find a OS child, they have to inform to the police, local police, or in a child line number or district child protection unit. Once they receive the call about this child, the child is taken in custody and it is handed over to a child care institute or special adoption agency. Then this adoption agency produces this child before the child welfare committee within 24 hours. So once the child is in custody of the police or adoption agency, they has to produce the child before CWC, and then this CWC will direct the police to advertise about the detail of the child in the newspaper or in that particular area, so that the biological parents of the child can trace that child if they want to take back the child. And if the parents do not if the parents don't want to take the child, if they don't come forward to take the child back, then this CWC committee declare the child as legally free. So this committee gives enough time to biological parents, around 3-4 months, so that they can come back and take the child again. But if within 3-4 months biological parents don't turn up, then this child will become a legally free child. Then this child is posted on website of CARA, and then anyone can from there take the child, adopt a child. So an OAS child cannot be taken directly in adoption. So it has to go through a proper channel and through proper process. This is the website which is called Central Adoption Resource Authority, which comes under the Ministry of Women and Child Development, Government of India. So this is the website where the parents register themselves on a caring software is there. You can see there is a software, parents can reach on this website, and then any parents who want to adopt a child has to go through this registration process on this website through caring software. Now, how the process is started? The adoption procedure for resident Indian. So once the parents register on Central Adoption Resource Authority, they are issued an identification or registration number, and then they are put in a seniority of waiting list. So as I told you, there were 35,000 parents who were in waiting list of seniority, and once their number come, they will be called in and they will refer a child. So it takes around 2 to 3 years when the number of waiting parents come and they get a referral. So it is very long time after registration, around 2 to 3 years, when the parents get a referral for children. Once the parents, pre-adoptive parents get a referral then the specialized adoption agency in that area. The parents are also given a choice for 2-3 different states. They can choose those states from where they can adopt a child. So suppose any parent choose Delhi, so the specialized adoption agencies, there are multiple specialized adoption agencies in those district or state. Then they contact to parents, and then they perform a home study. And when they perform home study, they look whether how is the financial condition, how is the environment of the family, or how is the marital status. So they put a home study of the parent on this caring software. So now the process adoption, once the parents get according based on their seniority level in the waiting list, they get around 3 referral with 1 month gap or 1 month interval. And if with the CSR, that is child study report and medical examination report. This child study report is prepared by adoption agency, and this medical examination report is prepared by a pediatrician or physician who is at district level. So any pediatrician or physician who are posted in government hospital or any specialist, as a specialist or physician, they can be called to examine the child and prepare a medical examination report. So this medical examination report and child study report is put on the website, and the parents can, after they accept a referral, they can see the child study report and medical examination report. So once the parents, PAPs, reserve a child within 48 hours, suppose they are given a referral, and within 48 hours, they have to reserve the child, that, okay, we are going to adopt this child. So once they reserve the child, the adoption agency fixes appointment with the adoption committee. This adoption committee work is that it matches the parent with the child, or the adoption committee assess the PAPs. So once the adoption committees finalize, okay, that the parents and child can be matched, then it is the PAPs who have to accept this proposal, and then the child is given to those parents for foster care until their adoption is legalized or through DM. So once the parents accept the child and keep it within the foster care, they can review the MER report or child study report to a medical practitioner or a pediatrician. So here comes the role of pediatrician. Then that once the parents get a child for adoption, before acceptance, they come to you and they can show you the report that whether the child is fine or having any special needs. So you have to see the medical report of the child, and you have to counsel the parents about the kid they are going to adopt. After acceptance of this proposal, the adoption agency file application to district magistrate, and the district magistrate passes the order within 60 days and issues a certificate that the child will be adopted to those parents. Now, a child who is put for referral on this website, if the age of that child is less than 5 years and child is normal, he will be referred for 60 days. If the child is a normal child age is more than 5 years, he will be put on CARA website for 30 days. And if the child is not placed, suppose no parents take the referral or don't accept that referral, so these kind of child who are not placed or not adopted, they are called hard to place child. So if PAPs do not reserve a child out of 3 referral, they will be debarred for 1 year. So every parent PAPs get 3 referral, and if they refuse all the 3 referral, they will be barred for 1 year. So, and if they after acceptance they don't accept they don't adopt the child, it is called disruption. And after finalization of adoption, if they don't adopt the child or it is dissoluted, they again shall be barred for adopting again. Once the child is adopted, then a post-adoption follow-up is done. The post-adoption follow-up is done by adoption agencies or district child protection unit on 6 monthly basis till 2 years of age after placement. So if the adoption agency find that the child is not adjusted or not matched to the parents, then before adoption, this can be disrupted. Means adoption can be disrupted before legally adoption process of the child. But if the parents has already adopted the child legally, but if the this adoption agency find the child is not able to match the environment of the family, so there will be annulment of the adoption, and it is called dissolution of the adoption. So this all done under the Juvenile Justice Act. Now, how a child study report is prepared and how a medical examination report should be made. Suppose you are a pediatrician or physician at district level, you have to prepare a medical examination report of a child. The child study report is prepared by a staff or social worker of adoption agency, which will give information, collect information about name, age, sex, religion, and about social data of the child, like intelligence, behavior, relationship, his dietary habits, milestone. So this is the child study report, which is prepared by a social worker. But the medical examination report is prepared by a physician or a pediatrician. So this is there are 4 headings, 5 headings under which you have to make a medical examination report. First is general information about the child, that the name, age, sex, and placed in which institution, placed before admission, about anthropometry, Apgar, LS, cesarean, normal delivery, and medical history about the mother, vaccination record, and the developmental history like visual, oral, motor, language, communication, the child emotions, how child expressions are, is the child remains very angry, uneasy, disappointed, how joyful. So this is about the medical history. Then the part C, which is important, very important, is medical examination detail. So the medical examination detail, you have to examine the child thoroughly, comprehensively from head to toe. Each and every system should be examined properly. So these are the like color of the hair, eyes, skin, how the child looks are there. Then growth parameters, physical examination with emphasis on neurological examination. So I don't need to tell you what the examination, you know already. And so you have to, but comprehensively and more emphasis on neurological examination you have to pay. Then you have to see the signs of disease, impairment, and abnormality. Especially whatever I have mentioned, you have to look for these problems like dysmorphic faces, hydrocephalus, craniotabes, cleft palate, vision-related problem, hearing problem, any heart and lung disease, hypospadiasis, undescended testes, any ambiguous genitalia. Is there any sequelae of meningitis, encephalitis, epilepsy, cerebral palsy, eczema, infection, parasites? So on your examination, you have to rule out these signs of disease or abnormalities. Also, you have to see the signs of any disease like tuberculosis, hepatitis B, syphilis. Is there any history of blood transfusion? And you have to also find out about the developmental delay, or is there any regression, neurobehavioral or neurodevelopmental disorder. So on your thorough examination, you have to find out or rule out these abnormalities or diseases. Now, after the examination, what screening test you will advise? So if the child age is less than 1 year and or newborn, the child is newborn, then you should go for ROP if the weight of the child was less than 2 kg, thyroid function test, OAEs, or if required, BERA, screening for critical congenital heart disease, pulse oximetry, or even you can go for echocardiography. And to rule out HBS hepatitis, you can do HBsAg, HIV, you can rule out HCV, VDRL. So you have to send all tests to rule out these problems. Basic CBC, LFT, KFT also you have to include in the screening test. And if the child is above 1 year of age, and if coming from a central western state or in high risk area where is hemoglobinopathy is there, you can go for CBC, hemoglobin electrophoresis, HbA1c. And also you will go for thyroid, TSH, HIV, HbA1c, HCV, BDRL test. And if you suspect symptoms or signs of TB, then you can go for PPD, chest X-ray, and basic investigations like CBC, TFT, LFT, and rule out rickets. Urine and stool examination is also important to rule out presence of any ketone or sugar or parasite in the stool. So these are the screening tests you have to do in a child if you get a chance to examine and investigate. Then if the child is, you already know these things that HIV, if you want to rule out the HIV and the child is less than 18 months of age, then HIV ELISA is not reliable. Then you have to be dependent on HIV DNA or HIV NA PCR. You have to do 2 tests 4 weeks apart. And if a child is non-breastfed and not exposed later after birth to breastfeeding, then a negative HIV ELISA test more than 9 months of age can also rule out HIV. But mainly, if the child is less than 18 months, should go for HIV DNA PCR. Then similarly, if to rule out HCV or to diagnose HCV in infants and children who are going to be adopted, so they are get this infection mostly from the vertical transmission. So anti-HIV, HCV antibody is not reliable. So you have to go for HCV RNA PCR. And again, you have to get 2 negative tests 2 to 3 months apart to confirm no infection. Then the fourth heading or fourth part is the developmental examination to know how is the child developing. So you have to do the thorough examination of the child, neurological examination. But for developmental milestone, you should know all the red flags in all 4 domains. Like that is gross motor, fine motor, socio-adaptive, and hearing. So these are the basic red flags you should know to see whether the child is having any developmental delay or not. Like in gross motor, the child is not sitting at 9 months or unable to walk at 18 months of age. In the fine motor, there are different red flags, but the child is not having no pincer grasp at 12 months or unable to scribble at 24 months. Similarly, in socio-adaptive area, the red flags is that there is no social smile at 2 months of age, or there is no finger pointing by 12 months of age. And if the child language is also not developed properly, like if the child is not able to use 2-word sentence at 2 months of age, or if the child by 2.5 years of age not able to make 2-word sentence, then and 42 months not able to make a simple sentence. So these are that means the child may be suffering for developmental delay, and you have to examine the child properly, and you have to mention all these points in the medical examination report. Then come to the special need condition. Does the child have these conditions? So these are these different conditions I have mentioned here. This from birth to later in the age. You can find on your examination that the child may be having sequelae of birth, asphyxia or neonatal sepsis, or from jaundice. Child had, you have to find out history of hypoglycemia, and is there any birth defect? So like ambiguous genitalia, cleft lip palate. So there are multiple problems which comes in the category of special need condition. And special need condition can be temporary or permanent. So if it is temporary, that means it can be treated. And if it is permanent, then you have to mention that it is permanent. And because parents had the right to know whether the child is suffering this special need can be treated or not. So other special need condition comes in neuromotor condition like cerebral palsy, muscular dystrophy, and in neurodevelopmental disorder like intellectual disability, ASD, ADHD. You can take help from a child's developmental pediatrician or child psychologist to prepare a report about the neurodevelopmental and behavior problems. There can be different orthopedic conditions. So you have to see whether the child is having any special need condition. And then come to just want to emphasize a special need condition, which is a fetal alcohol spectrum disorder. And you can easily miss it because normally in general population, we don't find it. But the kids who are OAS child, that the child who are abandoned, orphaned, or surrendered, there may be history of alcohol consumption in mother in pregnancy. But maybe if there is no, we can't find the maternal history, then we have to see this disorder, whether the child is suffering with this spectrum disorder or not. The fetal alcohol spectrum disorder comprises of different entities. The most severe end is fetal alcohol syndrome, where there is a physical defect of characterized by three characters, that is smooth philtrum. You can see there is a smooth philtrum, the thin upper lip, and small palpebral fissure. These are three main characteristics. And there could be growth deficit also, CNS microcephaly, and micrognathia, neurological and functional abnormality may be there. So this is called the fetal alcohol syndrome, which is the severe end of the fetal alcohol spectrum disorder. Another entities in this fetal alcohol spectrum disorders are alcohol-related neurodevelopmental disorder and neurobehavioral disorder, like NDPA, that is neurobehavioral disorder due to prenatal alcohol exposure. So there are mainly three areas where the child has problem in thinking and memory, behavior, and day-to-day living problems. Like thinking, child is not able to plan things. The child easily forgets the things easily. Behavior can be irritable. The child shows tantrums and he's not able to perform day-to-day living like bathing, dressing, or playing with the other kids. So child will not have these physical problems, but child will have only the neurobehavioral disorder with these three main areas involved. So you have to check the history of alcohol consumption in the pregnancy. And this alcohol consumption in pregnancy can also lead to alcohol-related birth defect like heart, kidney, bones, and hearing and vision. So though there is no safe dose of alcohol consumption in the pregnancy, but the American Psychiatric Association says that the alcohol during pregnancy, that is more than 13 drinks in 1 month or 13 drinks in 30 days, or 2 alcohol drink in one sitting, can be harmful, and they can lead to neurobehavioral disorder without any this abnormalities, physical abnormality. So you can confuse these problem with the autism or ADHD or different psychological problem. So you have to rule out, because this FASD is a FASD lasts lifetime. It doesn't have any cure. So only the early stimulation treatment service is important and some important protection factor are like, if you diagnose this condition less than 6 years of age, or there is loving, tender and stable environment in the family in school years, absence of violence, and involvement of the child in education services or social services, then they can protect the effect of FASD in the child. So this entity you should keep in mind once you are examining a child who is for adoption. Then we come to what are the impact on child after adoption. So once the child is adopted and he comes to home, so he can feel these emotions like feeling of rejection, loss and grief, identity crisis, self-esteem, intimacy, and attachment issues. So child feels that if the child is older in age, he can feel that the parents has abandoned him. So he can develop the feeling of rejection, loneliness. So this all depression, anxiety a child can have after adoption. And if a child comes from a family or a society or from an orphanage where there was scarcity of the food, so child can have these problems of overeating, holding of food, stealing food, picky eating, food anxiety. So you can overcome these problems by gradually do not punish. Tell the parents that they don't punish or don't make a shame of these things. And once the food is available in good quantity, and the child will gradually overcome this problem of overeating, hoarding. And if the child is picky eating or is coming from a different culture, so just give the food the child likes and then gradually introduce the different food. So this was the impact on child mind after adoption. Then the post adoption, there can be impact of parents. And what is important is that after adoption, parents can develop post adoption depression syndrome. This is not very common, but around 10 to 30% of the parents develop the post adoption depression syndrome, because once they realize that the reality is different from their imagination and expectation, so that the child they were expecting, they were imagining is different, so they can develop depression, bonding, and attachment issue. The another question arises that how and when to discuss the adoption with child. You have to some time in future you have to tell the child that he is adopted, but there is a way or should be a proper method to tell the child that you have been adopted, but you have to tell in certain way, like you can tell an interesting story to the child of adoption procedure, something like that. But the child after 3 years of age understand the difference between biological and adoptive family. So after 3 years, you can introduce the child with the adoption term, but you have to tell the child that he was adopted. So now we come to the conclusion that what are the different key points for the pediatrician. So if pre-adoption, you have to discourage illegal adoption to the parents and inform them different laws and procedure, discuss about the health record of the child in detail, and try to identify any special need the child is having through that medical examination report, with a special emphasis on genitalia, developmental delay, any neurological abnormality. And once the child is adopted, post-adoption, you have to see whether the child vaccination is complete or not. How is the child? Is there any protein allergy, malnutrition? Is there any nutritional deficiency, mineral deficiency? Or is the child having delayed milestone? Then you have to refer the child for proper therapy. And if there is any special need condition, you have to treat that particular condition. And the important thing is that you have to tell the parents that the cognitive stimulation of the child is very important, and child should be provided a loving and caring family atmosphere, so that he can enjoy that family, he can become familiar with family, and gradually he will learn that this is my family. So this was all about the adoption. Thank you so much. I request Dr. Satinder also just to give her views on the post-adoption impact on parents and child, if she can tell us about something about the post-adoption depression syndrome or feeling of rejection, how she handles that. So I request Dr. Satinder to please come over.
Thank you, Dr. Amit. It was very insightful, and especially the legal aspects, which are, I think, very, very important for everybody to know. Commonly, the most important thing which I have seen in adopted children is that parents don't discuss to their children they are adopted. They all say that we've been informed by the agencies that the children should be adopted, but they are not tell them on timely manner. And even as old as 11 years, 12 years, when I come across now children finding out themselves. Recently, the parent came and they said, we have not told our child that she's adopted, but she's saying that I am adopted. I know it. Look how you look and how my brother looks, and I look so different. And she was very cool about it, but they said they still didn't have the courage to tell the child that you're adopted. So they still felt very, very overwhelmed and skeptical about sharing this. And So many times I've seen parents who have disclosed to their children at early age onwards, as you said, 3 years is a good age. Those kids are very well settled emotionally. Even if they have some of the learning issues or some other behavioral issues, they are able to cope up as a family very well. The bonding and attachment issues are much stronger. The other aspects which also come across is that the parents are very, the grief which is not shared, because sometimes it is always viewed as that adoption is the best thing. It's the kids are lucky who got adopted, parents who adopted are lucky to have a kid. But a loss from a biological parent is always going to be there. Children's self-identity get impacted because they want to know from where they have come. Why were they being not taken care by the biological parents? Sometimes there is a access to biological parents, and if there is a difference of the economic stature, that also makes a lot of difference in their self-esteem from where they belong to. So these are the most common issues which I have come across, and I personally think that this should be reinforced more and more by the pediatricians also, that adoption should be told to children as early as possible and should not be hidden. And a lot of self-esteem issues, because also the looks are different, the cultural aspects can be different. So those are the issues which does come across among the children.
Thank you, Dr. Amit, for a wonderful presentation. And most importantly, for giving us the legal aspects of adoption, which I think many of us as pediatricians were not aware of. And of course, the medical aspects of it. Satinder, Dr. Satinder very well said that we should talk to them as pediatricians as early as possible. But even if we tell the parents, I have been dealing with a lot of my patients who have been adopted. Some of them have come to me at the age of 6 months, some at the age of 1 month. And we keep on telling them on every visit that they should talk to the children as early as possible. But somehow parents are not very, very comfortable in talking to the child. I don't know whether they feel they find it difficult to talk to, which is understandable. And they also say as to ki hum kaise baat kare. I don't know, Satinder, if Satinder can suggest something as to how we can talk to them. But normally what I suggest is that because ultimately the child will get to know, and the child will get to know from one of the relatives or from something or the child will definitely get to know. So how do we go about telling the child that you are an adopted child? Well, people say that telling them that you are, we are more blessed, because you are directly from God to us. I don't know. Satinder can maybe, give us some inputs as to how should a parent talk to a child that you've been adopted, and why you are so special to us. And yes, as you said that they have an identity crisis, which is definitely there. I have a child who is now 18 years old. She was adopted when she was 6 months old. And when she got to know very nice parents, nice educated parents, simple parents. And when she got to know that she was an adoptive, she had been adopted, she wanted to go to the place from where she had come, which the parents called up. I said, "Ha, please, I use it." She wanted to find out, check the registers where her name was there or not, who her parents were there. So that sort of a curiosity, that sort of a finding for urge to find out where they actually belonged will definitely be there. And yes, it leads to a lot of depression and low self-esteem to be rejected by your own biological parents. It is not easy. So I think Satinder can give us some insights as to how we can talk to the parent, how to tell the parents to talk to the child.
Most of the times, I think if it started earlier when the children start asking, because usually when they are in preschool, they started seeing their friends' parents being pregnant. And that's the age when they start asking, from where did I come? Did I come from your tummy? I think initiating the conversation from there onwards, letting them know that there are two ways of coming. One is biological and other is adoption. Initiating conversation at that point is very, very important, because it's easier at that point, because kids does not have emotional thing. They just are asking from where do we belong to. And that conversation keeps getting better eventually, because then the emotional connotation comes, and then we can explain them that, yes, you didn't come, but we've raised you. We are your parents. The recent research is saying that overuse of word that we are lucky, you are lucky, should not be used, because that's not a very appropriate way, because it should be taken as a normal process of being parenting. The other thing is, parents themselves sometimes are not prepared. They think that adoption is a big thing, and actually adopting a child becomes such a big process. During that process, they get so worn off, they forget that parenting itself is a very difficult task. So when the child comes, and many times adoptive kids also have neurodevelopmental disorders, and it becomes very challenging for parents to handle. I met one of the family where their biological child died, and they, just being very impulsive, had filed up for adoption, and just they got the child also, like unlike other parents who are there for many years. Once the child came, he was extremely ADHD and very oppositional child. And this mother cried and cried, and she said, I know it looks very inhuman, but I want to get rid of this child. And I am still grieving with the grief of my own biological child, who was a very bright kid. And now I'm having to take care of this child who is extremely needy, and I am not ready for that. But there is no other way I can, now there's no process to unadopt the child. So I think sometimes it becomes very impulsive for parents to go through that process and not be prepared for that. Parenting itself is challenging. So initiating the conversation from the beginning, letting them know that adoption is the way somebody else give you birth. When you said that they want to go and see where their name was written, those things keep coming as they keep growing, because I think we all have a urge to know where do we belong to. And that attachment is a very, very important. So attachment theory in humans, even in typical kids, if early years, if infancy and the parent relationship is not there, it impacts their growth, their social, emotional, and their self-esteem. So for parents, children to know from where they have come, and whatever information we have, if we can share with them, it gives a closure to them, because I think everybody has a right to know from where do they belong to. I think the most important thing is as honest as possible. That is the best thing. Hiding information, it always comes back in a negative manner. So honesty is kind of a best way to develop that relationship among adoptee child and adopted parent.
Another issue which, as pediatricians, we face in adoption is that they adopt a child, and then the mother gets pregnant and gets a biological baby. And I have seen the difference in the attitude of the mother in the towards the adoptive child and towards the biological child. I understand that maybe it is natural, but I don't know how to deal with it. I don't know.
That again, from the child's perspective, it's very unfortunate. And that's exactly what I think before any couple or an individual wants to go for adoption, I think they should do a good homework about their own self. What are the purpose? Because many times infertility also leads to adoption, and then the second baby happen. Having said that, there are many good stories. There are many families who have rearing up kids very beautifully. They have their own biological family, but they do have adopted kids along with them. I recently came across a principal of the school, and she's 60-year-old, so she couldn't legally adopt, but she has become that one of the law, Dr. Tyagi said, that guardianship. So they have taken a plumber's child who was in a very bad situation, and they have now nurtured her as their own. But again, the child has started asking, she's 7, 8 years old, that where do I belong to? And it's really, there's no answer who is the parent, who is the thing. They certainly are not parents, she understands. But that closure to it, that who is going to disclose where does she belong to, is still. So they came for the learning issues, but this came up that they have to really come up with a plan that how they are going to give this child information, where does she belongs to. So again, the later it starts coming from children, it becomes very difficult for them to cope with. If it started initial years only, it is much easier to communicate.
The later we tell them, the more possibility that they'll become defiant. I have seen it. And they become so defiant that they don't want to do anything, and they start rejecting their own parents. Maybe again, I tell those parents that this is probably just a temporary phase, and it will go away with love. So if you're honest to your child, if you are open to, but the only question that they want to know is, why didn't you tell me earlier first, and where do I belong to? So I've seen this in one of my patients who is now 17, 18 years old, and she became very defiant. It took a lot of toll on the parents to explain to her and to bring her back, but it was difficult.
Typically, adolescent age, they are anyways very defiant. So, and this additional burden comes in when they are themselves struggling with their self-image. That is the time the self-concept is still establishing, and a lot of children are struggling with that. So this additional thing definitely does do more damage than doing anything good.
Dr. Amit, could you please share the slide where you have shown the age for adoption of the child and including age for a single parent? And also there is a request to show the slide where important physical examination points have been listed.
So this is the age criteria. Sorry.
So there was a question that what is the upper limit of the age for a single parent to adopt a child?
If a single parent is more than 55-year age, you cannot adopt a child. If the composite age of couple is more than 110 years, they cannot adopt a child. So the maximum age limit for single parent is 55 years, beyond which they cannot adopt a child. And composite age is 110. So I think, and if the single parent has 40-year age, see, you have to see the difference. So what is the PAPs and child age difference? So if it is less than 25 years, the parents cannot adopt that child. Suppose the child is a 5-year-old and a parent, single parent is 24 years, they cannot adopt that child. So the minimum age difference should be 25 years or more.
And Dr. Amit, can you put up the slide for the physical examination features which we need to look for in a prospective adoptive child?
This is the medical examination. You have to examine a child as normally you examine any child you would examine. So these are the basically physical examination. You have to rule out these important abnormalities. So like dysmorphic faces, vision, reduced hearing, and hyposphadia, ambiguous genitalia. This is the basic diseases you have or abnormalities you have to rule out, and you have to do the examination thoroughly, comprehensively, as you do in any case, any normal child. So you have to rule out any symptoms of tuberculosis, sign of tuberculosis, hepatitis B, syphilis, any developmental delay or regression, neurobehavioral regression, or neurodevelopmental disorder. So this was the physical examination.
Dr. Amit, is there any system for follow-up of the child, how the child is being taken care of by the adoption agency?
Yes, once the child has been adopted, as I earlier shown in my slide, that once the child is adopted, then that specialized adoption agency or district child protection unit, their worker comes every 6 monthly to their home, and then they follow and they see the environment of the family, how is the child is adjusted in that family or not, is the child is being taken care well or not. So this follow-up is done after till 2 years after placement with EAPs. And there is some fee also for adoption, around 65,000 rupees the government charges. And this because of our child care fee and the fee for those follow-up and child study report, making child study report, making child medical examination report. So there is expenses involved in this adoption process also.
It's a very tedious process. If you go to Kaur website, many people are not able to fill if they are not very educated. So that's also a concern.
Take long time, maybe 2 to 3 year of waiting period according to the seniority list. So once you refuse a referral, then you have to go down in the waiting list. Then again you will get after 2 to 3 years. So it is very lengthy process.
Dr. Amit, can you put up the slide for the screening tests which were listed? There's a question in the chat box about the screening tests. Yeah.
So this is the screening test in a newborn to 1 year of age, less than 2 kg weight. You have to do screening for ROP, thyroid function test, OAEs, BERA, screening for congenital heart disease to rule out HPS-AZ, HIV, HCV, PDRL. And if parents want for screening for metabolic diseases, then you can go for, if the parents want, then you can go for tandem mass spectrometry in a dried blood spot, or you can go for urine GCMS also.
Despite all these screenings and complete physical examination, you still have to tell the parents that there would be areas where which cannot be detected as early as 1 month or 2 months of age, and the child may turn out to be autistic, or the child may have some ADHD issues which will not be detected early at the age of 1 month, 2 months, or 3 months. So these things have to be told to the parents. And most of the time what happens is that the bonding has already been established between the child and the parent, and they can deal with it. But I think this part has to be told, that even in your own child, you will not be able to detect ADHD or autism, something which will crop up later in the life, that certain things, everything cannot be 100% that okay, at 1 month or at 10 days this baby is absolutely okay. So this thing has to be told to the parents who are adopting the baby.
I think we don't have any further questions. So it's time to close the session. Thank you very much, Dr. Amit, for such a detailed and insightful presentation in emphasizing the role of a pediatrician in process of adoption, not only at the time of adoption, but also for the ongoing needs of the child and the family. I think pediatrician would be a key person to which patients would, the families can put their trust into. I'm thankful to our chairpersons, Dr. Shikha and Dr. Satinder, for sharing your personal experiences. And thank you all the participants for attending this session. And we will be posting the recording of this session on the YouTube channel of blkpediatricpractice.com. And the next webinar will be on the second Thursday of next month. Thank you so much, everyone.
Thank you, Dr. Swati.
Thank you, Dr. Swati, for taking all the initiative, Dr. Swati and Dr. Ankit, and please keep this going. It's a really good initiative.
Thank you.
Thank you, ma'am.
Yeah, everyone.